Hi guys, I'm Dr. Srin Sharma. Today's lecture is about vestibular neuronitis. It is inflammation of vestibular nerve. That is eighth nerve inflammation. This neuronitis is characterized by the definition is acute onset, severe incapacitating vertigo or dizziness followed by vomiting and nausea. So this is vestibular neuritis is acute onset severe incapacitating vertigo dizziness followed by vomiting and symptoms. This is classical presentation mostly after attack of URTI, upper respiratory tract infection, mostly viral infections. So this is mostly unilateral, most commonly unilateral. Incidence is about 3.5 is to 1 lakh population. Most common age of presentation is 30 to 60 year of age. It's equal in male and female. Ratio is equal in male and female. Vestibular neuritis is better term than vestibular neuronitis. Neuritis is better term than neuronitis because it is inflammation of nerve and perivascular infiltration of lymphocytes, not affecting individual neurons. So it's affecting perivascular and perineural structures like this is the neuron and this is the nerve and this is the neuron. So this is affecting, this is perivascular infiltrates. So this is mostly affecting the perivascular region of affecting nerves, not affecting individual neurons. So better term is neuritis, not neuronitis. Even though we can call it vestibular neuronitis, but we have to follow better term is vestibular neuritis. Now, what is diagnostic criteria? What's modified diagnostic criteria? The scientist quotes given some definition of diagnostic vestibular neuronitis. First definition is it is acute onset severe vertigo which is mostly non-recurrent. In 95% cases it is non-recurrent, not happen again. Okay, acute onset severe vertigo, it's mostly unilateral, partial or complete vestibular dysfunction. Third one is absent of cochlear sign and symptoms and CNS signs or symptoms. It is absent of cochlear involvement or CNS involvement. And fourth one is complete recovery within 6 months, maximum within 6 months. So this is course modified diagnostic criteria for vestibular neuronitis. This patient of vestibular neuronitis is present with acute onset severe vertigo, which mostly non-recurrent. Unilateral involvement is more common. It's partial or complete vestibular dysfunction or absence of any cochlea like decreased hearing, tinnitus, and absent of cochlear signs and symptoms of CNS sign involvement and complete recovery within 6 months. This is the course diagnostic criteria of vestibular neuritis. This is most commonly affecting the superior vestibular nerve than the inferior vestibular nerve. Over 82% cases, superior vestibular nerve is most commonly affected by vestibular neuronitis, and 18% cases it's affecting inferior vestibular nerve. About 2% cases having both. It may, in 2% cases, it may affect superior vestibular nerve and inferior vestibular nerve also. So, in 82% cases, it is affecting superior vestibular nerve only because of its narrow and long course. This superior vestibular nerve is having narrow canal and long course, that's why it's commonly affected MCQ. Okay, in vestibular neuritis. Another thing, this vestibular neuritis characterized by inflammation of perivascular lymphocytes and infiltrates of other neutrophils around the nerve. This superior vestibular nerve is characterized by horizontal, torsional nystagmus. The characteristic symptom is horizontal torsional nystagmus. If it is vertical nystagmus, if vertical nystagmus there, always think about central cause. If it is vertical component is there, don't consider vestibular neuronitis. We have to follow. If it is vestibular vertical nystagmus there, we have to rule out central pathology. Now, how to diagnose this? And this vestibular neuritis is most commonly caused by herpes simplex virus type 1, that facial nerve virus. Same virus having facial palsy, Bell's palsy, same virus is here for vestibular neuritis. It may cause by Epstein-Barr virus, CMV virus, adenovirus, and most commonly 90% of cases it is caused by herpes simplex type 1 virus after following attack of URTI. This diagnostic criteria we can say The new term is hint. Hint. Hint means you have to diagnose by head impulse test, head impulse test, test called nystagmus. Most commonly we are doing video nystagmography or electro nystagmography, and tests of skew or sway or deviation. These tests are mostly we are doing Romberg test, Unterberger test, or test of Gates. These tests we are following for diagnosis. In head impulse test, if we are doing like this motion, so we can see there is nystagmus on the affected side of the lesion. Okay, the head impulse test is positive on the affected side, but nystagmus is always opposite to the lesion. So head impulse test is positive on the same side. A test of skew is also, and so if you are doing Romberg test or Unterberger test, they are also positive on the same side. Suppose this side is having, right side is having vestibular neuritis. So we can sway away and we are supposed to fall on the right side. Nystagmus is always suggestive on the opposite side of the lesion. So if we are feeling nystagmus on right side, so lesion should be on the left side of the lesion. So by doing these hint test, head impulse test, nystagmus, and test of skew, we can diagnose the vestibular neuritis. It is having classical presentation. If you are find any vertical component in nystagmus, so you can see it is always because of central pathology. Most common central pathology you have to rule out is pica syndrome, posterior inferior cerebral artery, posterior inferior cerebral artery syndrome. Second one is acute vestibular artery syndrome or any central stroke. So you have to rule out by doing multiple MRI or CT scan or clinical examination of central nervous system to rule out this pica and acute vestibular artery syndrome. Most of the cases of vestibular neuritis present with severe dizziness of 3 days, mild moderate symptom of 3 weeks, and mild symptom of 3 months. So this is the course. Even this patient may have mild symptom to 3 months. You have to give symptomatic treatment only. So this is the classical presentation, and most of the patient like to lie down on the bed till the symptom resolves. Now another very important test to rule out which particular branch is affected, that is called BEM test. This is vestibular evoked myogenic potential. If you want to know which nerve is affected, superior vestibular nerve or inferior vestibular nerve, then which nerve? Vestibular, superior vestibular nerve neuritis or inferior vestibular neuritis? Then you have to do BEM test. That is vestibular evoked myogenic potential. In this test, we are giving 60 decibel. sound click to the particular ear. If you see this vestibular evoked myogenic potential is based on the mechanism of action is vestibular ocular reflex. If you see, if VIII is two types, this is ocular VIII and this is cervical VIII. Okay, if we are giving ocular VIII, if we are monitoring, if we are giving this utricals, the sound of 60 decibel, this pathway leading to superior vestibular nerve goes into the superior vestibular nuclei, which lead to the opposite side of the medial longitudinal fascicles, which in the third nucleus, which ultimately supply the four muscles of the nerve, and mostly this pathway leading by inferior oblique muscle of the eye. So if we are testing the superior vestibular nerve, the pathway, if we find out giving the sound of the 60 decibel, we will find out the opposite abnormal of O-vamp in the side of the lesion. In cervical vamp testing, we find out the same side of the lesion. If we stimulate the sternocleidomastoid muscle is activated or decrease absence of stimuli in the vamp because of this vestibular neuronitis. So you can say for this, if you activating the giving sound to the 60 decibel, the root is inferior vestibular nerve, inferior vestibular nuclei, medial vestibulospinal tract, leading to decrease contraction or diminished response of sternocleidomastoid muscle. Contraction is C-vamp on the same side of the lesion in inferior vestibular nerve pathway. So by vamp we can find out which branch is affected. Like we can say O-vamp. O-vamp in O-vamp is abnormal or diminished response in superior vestibular nerve and opposite side. But this O-vamp is normal in inferior vestibular neuritis. Same as if we are doing C-vamp, this is abnormal response or diminished response in inferior vestibular neuritis and normal response in superior vestibular neuritis or superior vestibular neuritis. If both are affected, so C and B O-vamp is abnormal if both nerve are involved. If both are involved in neuritis, then it is cervical and ocular both vamp are abnormal or diminished response. Now, what is the therapy? Therapy you can do for acute symptoms, you have to give symptomatic treatment. You can have like anti-emetic medications, anti-vertigo treatment like meclizine, prochlorperazine, stametil, beta-estine. You can give for symptomatic treatment. You can give steroid therapy. State dose of 4 to 8 milligram dexamethasone. That is very effective in acute attack. You can say it is therapy of choice in acute attack of vestibular neuritis. So you have to give steroid therapy, dexamethasone, methylprednisolone you can give. Another therapy you require that is most effective is vestibular rehabilitation protocol. You have to give vestibular rehabilitation therapy and cognitive therapy also. So this is, if it is chronic, the therapy of choice is vestibular rehabilitation therapy. If it is acute, therapy of choice is steroids. So this is the MCQ. If it is within 7 days, you have to treat the acute symptom by vestibular neuritis. Then therapy of choice is steroids, methylprednisolone, or dexamethasone. If it is chronic, then you have to give vestibular rehabilitation therapy. So this is all about vestibular neuritis. Thank you so much.